Okay, guys. Okay, guys. Okay, guys. Yeah, shall we start? Audio and video, everything okay? Okay, guys. Yeah, shall we start? Audio and video, everything okay? Okay, guys. Yeah, shall we start? Audio and video, everything okay? Okay, guys. Yes, guys. So I think everybody can see me. Yes. Shall we start? Yeah. Okay, guys. Everybody can see me. Yes. Shall we start? Yes. Yeah. Okay. So guys, let's quickly start this discussion. Basically, so this was a quiz that we did in inflammation and neoplasia, and let's quickly discuss it. So one of them was a very simple question that was asked: what is the working principle of thromboelastography? So we'll discuss more about it when we study hematology. But for this is one of the repeat question that you should remember. Thromboelastography is one of the point of care testing. Okay, so what is this called as point of care testing? क्या मतलब होता है पॉइंट ऑफ केयर टेस्टिंग का? पॉइंट ऑफ केयर टेस्टिंग इज वन टेस्टिंग व्हिच यू कैन डू ऑन द ओटी टेबल इटसेल्फ. ठीक है, सो व्हेन यू हैव अ पेशेंट विद यू एंड यू वांट टू immediately identify whether the patient is going to bleed or not, especially in the patients who have a high tendency of bleeding, big surgeries like cardiothoracic surgeries, brain surgeries. In such patients we usually do thromboelastography. So it is based upon the viscoelastic property of the viscoelastic property. And what do we do is, as soon as we take the blood, immediately it starts forming the clotting, and it also analyzes the fibrinolysis. So in that way, it basically identifies, it identifies thromboelastography very nicely. So it identifies the tendency of the patient to bleed, or what is the tendency of the patient to, how is the coagulation system working. So on that basis we give the treatment. Okay, so if the clotting factors are less, we'll give ffp. If the amplify, we have various graphs that we have. So on that basis we can give the therapy. We'll talk more about it later, but for now just one point: thromboelastography is based upon the viscoelastic property of the blood. It can measure the coagulation and fibrinolytic system immediately. It's a point of care testing, and you can give therapy to the patients on the basis of thromboelastography. Okay, so that's one point that you all have to know. Now, once we are clear with this, let's go to the second thing. So this was another question that was there, and which many students did wrong also. So this is GNARC mutation. We have asked this question previously also. So remember, whenever I'm talking about which are the proteins involved in signal transduction, so this is a snapshot from Robin's textbook, and this basically says which are the proteins involved in signal transduction. Always remember that whenever we're talking about proteins involved in signal transduction, one of the most important proteins are GTP binding proteins, and one of the main molecules here are RAS molecules. So we have three RAS: KRAS, HRAS, and NRAS. Okay, so remember KRAS is basically, always remember the formula, that is CLP. It is involved in colon cancer, lung cancer, and pancreatic tumors. Okay, one of the very common mutation of pancreatic cancer. Now HRAS is very typical for, remember always, BK, that is bladder and kidney tumors. Okay, so bladder and kidney is HRAS. Okay, NRAS, whenever I'm talking about, it is basically in melanomas, and recently it has been also found in hematological neoplasms. Okay, so these three to aane hi hai. Okay, so these three must be known for everybody. These are very three important things that you have to remember. Apart from that, what you have to remember here is, the next important thing that you have to remember here is that there are two separate proteins which we should know here. One is called GNAC, and the other is called as GNAS. So this is two important proteins that you should remember. So when I'm telling about Q is uveal melanomas. Okay, so uveal melanomas is GNAQ, and that was the question that was asked. It is basically uveal melanomas. Okay, whereas when I'm saying GNAS, okay, so S is P. Okay, so S is P. It is pituitary adenomas. Okay, it's pituitary adenomas. So pituitary adenoma, if the question is there, you should remember the mutation in pituitary adenomas as GNAS. Okay, so that is very, very important. If somebody asks you bladder cancer, remember it as HRAS. Okay, HRAS. So that is very important that you have to remember. So these are the genes that everybody should be very clear with. An important question is asked in that. Okay, so they can also ask you which are the other proteins which are involved in signal transduction apart from GTP binding protein. Remember ABL. So ABL BCR translocation is seen in CML. Also remember RAS, all the RAS proteins undergo point mutation for giving rise to cancer, and they are all proto-oncogenes. They turn into oncogenes by point mutation. Okay. Apart from that, tyrosine kinase pathway, this is non-receptor tyrosine kinase pathway. That is one thing which you have to remember. And again, these are the small things that they ask you in exam as a question. So it's a non-receptor tyrosine kinase. Also remember that it undergoes translocation. If I am talking about the RAS signal transduction pathway, here the protein is BRAF, and BRAF is another very favorite question of examiners. Remember 100% of hairy cell leukemia, Langerhans cell histiocytosis, pilocytic astrocytoma has BRAF mutation, but it is BRAF Kia. Okay, that you have to remember. Apart from that, papillary carcinoma, thyroid, most common mutation, colon cancer, and melanoma. So these are the 6 cancers which are usually associated with BRAF mutation. Again, it's a very commonly asked question. Okay. Apart from that, we have Notch pathway, which is usually involved in signal transduction, and it is involved in leukemia, lymphomas, and breast carcinomas. And JAK2 is involved in myeloproliferative neoplasms, especially the polycythemia vera. Okay. And the typical mutation here is V617F. Okay. So it's a point mutation where valine is replaced by phenylalanine. Okay, so that is very, very important. Okay, so these are the mutations these are the proto-oncogenes which change into oncogenes. All of them usually most commonly signal transduction proteins undergo point mutation, whether it is a BRAF, whether it is a Notch, or whether it is a JAK2. But JAK2 also undergoes translocation. That is what one thing that you have to remember. Apart from that, ABL always undergoes translocation because it is 922 translocation. Remember, ABL is present on chromosome number 9. BCR is the second alphabet, so it is present on 22. So BCR is 22. Okay, so remember that. So ABL is a proto-oncogene which becomes oncogene by translocation. And which is Philadelphia chromosome, if somebody asks you. So Philadelphia chromosome is present on chromosome number 22. So don't do this wrong. Remember, what is a proto-oncogene in BCR ABL? ABL is a proto-oncogene. And what is a Philadelphia chromosome? It is 22 chromosome because the translocation occurs on that. Okay, ABL BCL translocation occurs on chromosome number 22. So that is why that is called as Philadelphia chromosome. Okay, perfect, Lakshit. Very good, Anand. Okay. Right, guys. So that is about this mutation that you have to remember. So which of these sarcomas show lymphatic spread? That is another question that was asked. So please, everybody remember, there is a very simple code that I have already given you. So remember, this is called as SCARE-FU. Okay, so SCARE-FU. So first is synovial sarcoma. It usually undergoes lymphatic spread. Then clear cell carcinoma, clear cell sarcoma, sorry. Okay, so that also undergoes lymphatic spread. Okay, so SCARE. Okay, C we have done. Then A is angiosarcoma, R is rhabdomyosarcoma. Okay. Then E is your epithelioid sarcoma, F is fibrosarcoma, and U is your undifferentiated pleomorphic sarcomas. So these are common sarcomas. Normally, sarcomas will always spread by vascular route. Okay, but there are very few sarcomas which are spread by lymphatic routes, and so you have to remember these. Okay, in this, synovial sarcoma is very important. Another points that you have to remember is, please remember, synovial sarcoma is a biphasic sarcoma because this is positive for both CK and Vimentin. Normally, all the sarcomas are positive for Vimentin. Okay, positive for Vimentin. Here you have to remember additional point that rhabdomyosarcomas are skeletal muscle, so they will be positive for desmoglein. desmin also. So whether it is a rhabdomyoma or rhabdomyosarcoma, anything rhabdo means skeletal muscle, and it will be positive for desmin. Okay. Whereas synovial sarcoma is a biphasic sarcoma and it is positive for CK also. Okay. So CK and vimentin both, because it has an epithelial component also and sarcoma also. So that is what is important about synovial sarcoma. Therefore, synovial sarcoma is one of the favorite questions that is asked by examiners all of the time. Okay. Apart from that, in angiosarcoma, they typically ask you that what is the most common trigger for angiosarcomas. So this is a radio contrast dye called as thorotrast. Okay, sorry, thorotrast, which is a radio contrast dye, and this thorotrast typically causes angiosarcoma. So that's another thing that you all have to remember. Okay. Now, which of the following, which of these relations between the chronic inflammation and cancer is correct? This is again a very important table from Robbins, table 7.4 from Robbins, which is very important. Please remember that chronic inflammation usually give rise to cancer. So which chronic inflammation will give rise to what? You should remember. So Sjogren syndrome is associated with maltoma. That all of you know that maltomas are usually associated with chronic inflammations, and Sjogren is one of them. Okay, there was a question on maltoma this time in INICT also. So you should remember the insights. Okay, the causative agents of maltomas. Okay, so Sjogren is one of them. Very important. Apart from that, if somebody asks you lichen sclerosis, remember it causes vulvar squamous cell carcinoma. So lichen sclerosis is an important trigger for vulvar squamous cell carcinoma. H. pylori, all of you know that it causes stomach cancer. So obviously you know that. Okay. So we have just talked about Sjogren and Hashimoto, which causes maltoma. Okay. So lichen sclerosis causes vulvar squamous cell carcinoma, which we have just now talked about. Okay. H. pylori, all of you know. Okay. H. pylori can also cause maltoma of the stomach. It can also cause maltoma of this lymphoma of the stomach, basically maltoma of the stomach. Okay. And IBD. So this is very important. Inflammatory bowel disease typically causes colorectal carcinoma. Typically causes colorectal carcinoma. Please remember, Barrett esophagus causes adenocarcinoma of the esophagus in the lower 1/3. Okay, remember that always. Plus, osteomyelitis typically causes carcinoma in the draining sites. So you're going to tell me in the comments below what is the carcinoma in the draining site also called as. What is the other name for that? Please write in the comments below. Apart from that, you should remember that schistosomia and chronic inflammation by schistosomia typically causes bladder cancer, and it is squamous cell carcinoma of the bladder. So normal bladder cancer is transitional cell carcinoma, but if you're getting squamous cell carcinoma of the bladder, always think of schistosomia, right? Let's go to the next question. So this was another question that was given to you, and this was about which molecule causes migration of the endothelial cells to cause new capillary. This was done wrong by majority of the people. Please remember here these three, cytokeratin, lamin, and bimentin are intermediate filaments. So intermediate filament just provide the tensile strength. Okay, so these are the intermediate filaments of the cell, and they will only provide the tensile strength. Okay, so they are not related to any movement. Okay, so they will just provide tensile strength. Remember, immunohistochemistry of the cell was first developed on the basis of intermediate filaments. Okay, it is actin and microtubules which help in movement. Okay, so actin and microtubules will help in the movement. So that is why the answer to this question was actin. So movement is the function of actin and microtubules. Okay. Coming to the next question. So this was about thyroid cancer, a very important question. Please remember, this is amyloid, pink color material which is deposited is amyloid. Along with that, these kind of plasmacytoid cells which you're seeing here, this very typically is medullary carcinoma. Okay, so medullary carcinoma of the thyroid. And all of you, I hope all of you have seen one video that I posted on the Instagram also about men syndromes. So once you see med is this med is basically story about your men syndromes. Men syndrome stories about men before and after going to the medical school. So before they go to the medical school, they love everybody. So they are pan lovers, okay? But they're doubtful for everything. So they do per, and they have pituitary tumors. Okay, so they are pan perpet. So before medical school, this is called men 1. Okay, so men 1 is before medical school. Once they go to the medical school, they become men 2. Okay, so before they enter into the medical school, they are 2A, and once they are ready to leave the medical school, they are 2B. So when they're 2A, now they have entered into the medical school, so they are med. Okay, so med तो उनके साथ हमेशा attach हो जाएगा. Now they are now they love only one person. Okay, in their life. Okay, just a second, guys. Okay, so now they love only one person in their life, that is Fio. Fio is their sweethearts, which will always remain their sweetheart. So it's Fio lovers. But when they enter into the medical school, they are still in doubt. So they still have par in their life. So they're doubtful about everything. But once they leave the medical school, now they don't have any doubt. Okay, so they don't have any thyroid. Okay, they will not have any doubt, and they will basically now be tall and long, so they will have morphonoid features, and they will also be very brainy, so they will have neuromas. So they will also have neuromas. Okay, ganglioneuromas and neuromas. So that's very typical for them, that you have to remember. So that is meant 2A and 2B that you should remember. Okay, what is Pragtri asking? Ma'am, H. pylori. H. pylori doesn't cause, the option that was given here was small intestine, no, bacho. So the question was H. pylori was small intestine. It doesn't cause a small intestine. It is gastric cancer and gastric maltoma. Okay, that is why it was wrong. So question was, which is correct? Which is correct? Correct is Sjogren and maltoma. Lichen sclerosis does not cause lung cancer. IBD does not cause leukemia. H. pylori does not cause small intestine cancer. I hope it's clear, Praktri, now. Yes? Okay. Right. Thank you, Anand. Thank you. Okay, Lakshit. Good. So that was about your medullary carcinoma first. So now we know that medullary carcinoma usually, so the question is, which is not true about this tumor. Now you know it's a medullary carcinoma. So it arises from the parafollicular cells. So that is true. And it can be associated with either MEN2A or 2B. That is also correct. Now MEN2 is very typically involved with the RET. Okay, so RET is the main gene which is involved here. Okay, so MEN2 is typically associated with RET. MEN1 is basically associated with a gene called MEN1 only. So it codes for menin. Okay, so menin is the gene here. So that is what is the difference here. So MEN2 are usually associated with RET, not RAS. RAS we have just now studied. RAS is a very important proton gene which everybody should know, and they can ask you this question so many times. So everybody should be very clear about this. Okay, so RAS does not play its role. It's RET that plays the role, and tumor secrete calcitonin. That is also true. Okay, so this is one thing which you should know. So whenever there were two questions on the thyroid, very good, Lakshit. Okay, so there were two questions on thyroid. One was medullary and the other was papillary. So the question was, everybody knows these are orphan ani. Okay, nucleus. They are optically clear nucleus. This is orphan ani nucleus, and I've already told you that this is a formalin fixation artifact. So those who have listened to me earlier also, so this is your formalin fixation artifact. It occurs because of formalin, and that is why this is one artifact which will be seen only on biopsy or excision specimen. So this change will not be seen in FNAC. That's another question that they can ask you. So this change will never be seen on FNAC. So remember, this nuclear clearing is a very typical formalin fixation artifact, and it will not be seen on FNACs. Okay. So apart from that, if papillary carcinoma, what are the other things you should remember? They have papillary, they have nuclear grooving, they have intranuclear inclusions, they have optical clearing, which is called as orphan ani nucleus. And the most common mutation for papillary carcinoma, which we have just now talked, is BRAF. So most common mutation of papillary carcinoma is BRAF. Apart from that, all of you should remember that papillary carcinoma is one of the most common, now not most common, second most common. Okay, second most common cancer which occurs after radiation in children. So whenever patient is having papillary thyroid carcinoma in childhood age, that is this very strong risk factor is basically your radiation. Always remember that. Okay, so that's one point that everybody should be very, very clear with. Okay. Now, once we are clear with this, let's come to the some IHC questions that were given to you. So, patient is said to have a mass in the lung, which is biopsied, and on examination, this is positive for CK7 and CK20. What is the site? So, we have already talked about CK7 and CK20. So, you have to draw a line above your colon, and you can make tumors on 4 bases. So, either they are CK7 positive and 20 negative, either they are CK7 negative and 20 positive, or they are both negative, Okay, 7 negative, 20 negative, or they are both positive. So 7 negative, 20 negative, or they are both positive. 7 positive, 20 positive. So whenever both are positive, B for B, it is usually bladder cancer. Both are negative, it is usually the cancer which do not follow the rule of carcinomas. That is, they don't follow the carcinoma, usually follow the lymphatics. So these are the carcinomas which follows the veins. Okay, so this is liver and kidney and the prostate. Okay, so they are both negative. Okay, then 20 positive is colon. Apart from that, Merkel cell carcinoma. Okay, Merkel cell carcinoma shows you dot-like positivity. Okay, so dot-like positivity of CK20 is Merkel cell carcinoma, which is a neuroendocrine carcinoma of skin. And 7 positive is all thing above. Okay, so it can be thyroid, breast. Okay, so all the cancer, lung, all those above is usually 7 positive. Okay, so that is what you have to remember. So that was the question. So this was both positive, and most of you did it correct only. It is blood. Okay. Now coming to the another question that was on this, this was question number 19. So patient has colon carcinoma, which marker will not be positive? So remember, these are screening markers, but definitive marker for colon cancer is CDX2. So this is always positive in colon cancer. CK20 is positive in colon cancer. You know, CEA is also positive in colon cancer. Now all of you should remember CK7 is a marker which is not positive in colon cancer. Remember this category always. So it's 7 negative. So that was the answer. And surprisingly, only 46% of the people did this correct. Okay, so that is why this is important question to discuss. Okay, so what is about this mutational hotspot, guys? So mutational hotspot is a new update in chemical carcinogenesis, that chemicals, whenever they target any gene or a DNA, they target at the hotspots. And these hotspots are very, very important. So they are particular DNA sequences which are affected by a particular chemical. And the classical example for this is aflatoxin. So aflatoxin typically affect codon 249 of P53. So whenever codon 249 of P53 is affected, you should always think of aflatoxin induced liver damage. Okay, so this is a very classical point about hotspot. Okay, so beta catenin is not affected in aflatoxin. Beta catenin is one of the very common mutation of hepatocellular carcinoma, no doubt about it, but it is not associated with aflatoxin. So what is the hotspot of aflatoxin? It is codon 249 of P53, and that is why the answer was only A and B, which is correct. So yes, 50% of you did it correctly. So yes, so that is about mutational hotspot. Okay. Now coming to the Warburg effect, this we have already discussed in the group also. I think somebody asked in the group. So yes, we know that Warburg effect is very typically aerobic glycolysis, and in this the cancer cells convert glucose to lactose. But remember, what is the uniqueness, which is not true, is ATP production is not high. So Warburg effect, so glycolysis produces only 2 ATP as compared to the 24 ATP which is produced by the oxidative phosphorylation. So ATP production is not high. Okay, so that is not high, but this is basically aerobic glycolysis, and in the presence of oxygen also glycolysis is used, which converts glucose to lactose. So all the intermediates which are used produced are used by cancer for the growth, and this glucose hungry nature of the cancer cell is used in PET scan. Okay, so that is used in PET scan. So that is what you all have to remember. Okay, so that is very, very classical here. Okay. Okay, so the answer is B here, and 72% of you did it correct. So, okay. Now, next question was this simple question, which is not associated with granuloma formation, guys. So, whenever I'm talking about granulomas, all of you should know there are rare causes of the granulomas also, which you should remember. So, syphilitic granuloma is rich in plasma cells. So, this plasma cell rich granuloma of syphilis is called as gamma. Okay. Rheumatoid arthritis granuloma, when I'm talking about it, typically shows you palisaded granuloma. That is, there is palisading, okay, on both sides. Okay, so that is rheumatoid arthritis granuloma. Vaginous, everybody knows, it causes granuloma with geographical necrosis. So there are large areas of necrosis. Geographical necrosis is seen in vaginous. Microscopic polyangiitis usually do not show you granuloma. It's not a condition of granuloma. So remember, remember, my closest differential of microscopic polyangiitis is hypersensitivity vasculitis, and the difference is that so we have to identify this. So this is microscopic polyangiitis is a small vessel vasculitis that you should remember. Okay, so we have to remember this important thing. Okay, so we always do an IgA testing in it. Okay, so if the IgA is positive in this, so this so these kind of vasculitis, small vessel vasculitis, can also be seen in Henoch-Schönlein purpura. So we have to know that whether it is an hypersensitivity vasculitis or IgA vasculitis. So if IgA comes positive, we label it as IgA vasculitis, which is seen in Henoch-Schönlein purpura. If IgA is not coming positive, we label it as an hypersensitivity vasculitis. Okay, that is one thing that you have to remember. So microscopic polyangiitis is one of the important vasculitis that you have to remember. Okay, it's a small vessel vasculitis, also called hypersensitivity vasculitis. Usually IgA is not positive in it. Okay, right. So that is about this vasculitis. So it is not associated with granuloma. Apart from that, all the other conditions which I mentioned on the top are rare and they are associated with granulomas, and they have named granulomas. Like gamma is a granuloma of syphilis, and geographical necrosis granulomas with Wegener's, palisading granulomas as with rheumatoid arthritis. So these are things that you should remember. Okay. Apart from that, there is another named granuloma which is usually asked in the exam. This is Dirk's granuloma, and remember that is seen in malaria. So Dirk's granuloma is seen in malaria, and it contains your black hemazoin pigment. So they can ask you which pigment is present on it. It is hemazoin pigment. Okay. About microscopic polyangiitis, they can ask you which type of vasculitis it is. It is leukocytoclastic vasculitis. Okay. So leukocytoclastic vasculitis. What is that? That means the blood vessels, okay, are infiltrated by broken up WBCs. Okay. So WBCs are broken up. Okay. So that is leukocytoclastic vasculitis that you should remember here. Okay. So good. Very good. Okay, so that is it. So this question is again asked again and again, and it's a NEET level question. Okay, so which is a not a negative acute phase reactant? The question was not. Okay, so you should remember here the negative acute most common negative acute phase reactant is albumin because it decreases with inflammation. Apart from that, transferrin, transthyretin, both are negative acute phase reactant along with retinol binding protein. The code is star, transferrin, transthyretin, okay, and albumin. They are negative. Alpha-1 antitrypsin is a very good positive acute phase reactant, and it increases with inflammation. So the answer was alpha-1 antitrypsin. Strangely, only 46% of the people did it correct. So that's why I thought let's discuss it. Another important question, please revise it before you go for the exam. So this was another update also. So that's why I added this, which is the most common carcinoma to occur by chromothripsis. So chromothripsis is chromosome shattering. It's a snapshot from Robbins here. So this is observed in 1 to 2% of the cancers in general, and they are very common with osteosarcomas and gliomas. Okay. Apart from that, there is a very typical type of ALL. Okay. So this is okay, so when intrachromosomal amplification of chromosome 21 is seen, this is also caused by chromothripsis. Okay, so these are 3 common cancers which occur by chromosome shattering: osteosarcoma, glioma, and in IAM21 in ALL. So these are very 3 common cancers. So that's why you should know that which are the cancers which are caused by chromothripsis, and they can ask you this as a question. Okay. Okay, so next question was the Darwin's theory. This is a repeat question which is asked long back in the JIPMA. So this is an important point concept that you have to remember. So there's a difference between tumor evolution and tumor growth, bacha log. Tumor evolution matlab hota hai that how does tumor changes with time? How does it evolutes? So this follows Darwin's principle. That is, first mutation occurs is first mutation, and then it changes to another depending upon how many passenger mutation it is acquiring. So the first mutation that causes cancer is driver mutation, and it is the first change that causes the cancer. So this is the Darwin flinches which is written here. So it was the first change that causes cancer is the driver mutation, and then in the bus lot of passengers sit. So more the number of passengers, more the profit in the bus. Same way tumor also same thing happens. The first mutation that causes cancer is your driver mutation, and more the number of extra mutations that occur is a passenger mutation. So this is what you should be knowing. Okay, so that is tumor evolution follows Darwin flinches. Now tumor growth follows Gompertzian curve. Okay, so that's another question that they ask you. Gompertzian growth curve is tumor growth curve. That is, by the time you pick up the cancer cells are 10 raised to power 9. So that is why you are detecting a cancer at a very late stage. Okay, so you are detecting it when the tumor cells are 10 raised to power 9. So now by the time the cancer cells become 10 raised to power 12, the patient will die. So that is why there is a long time period when we are missing the patients. So this is why we detect the patient only when the lump appears. So by that time, 10 raised to power 9 tumor cells are there. So this curve basically tells you that tumor growth kitni ho gayi hai. So by the time 10 raised to power 9 cells are there, then only you're picking up. That is why there is a scope of diagnosis much, much before the lump appears. And that is where the concept of liquid biopsy came in. That is, you should detect the cancer cells before the mass becomes evident. Okay, that is what is called as liquid biopsy. So that is what everybody should be very clear. So Darwin theory was tumor evolution. Tumor growth is Gompertzian. Okay, so that is what you should be clear. Okay, so very few people did it correct. So definitely this was another question that needs discussion. So there come we come to the concept of liquid biopsy. So I told you there's a lot of scope before which the cancer can be detected, and this is again a recent update also. So these are called scalpel free biopsies. That is, lumpy nahi hai to scalpel kyun use karoge? You don't need to use the scalpel itself. Okay, so how do we use scalpel free biopsies or liquid biopsy? So there comes the concept of liquid biopsy, that every tumor cell sheds some protein and DNA into the bloodstream, which can be detected, and once you detect them, you can detect the cancer early. And there's a very beautiful snapshot from the Robbins which says that we have liquid biopsy, which we can detect the circulating tumor cells. Not only that, we can also detect the circulating RNA which is shed in the blood from the tumor cells. And these circulating RNAs contains exosomes, nothing but there are some endocytic vesicles which are there, and they are rich in microRNAs also. And they help in transferring the material from one cell to the other cell. So these are very importantly present. And if you detect them, so whenever cancer cells are producing them, they have cancer microRNA. So you can pick them up and you can identify them. So remember, any circulating tumor RNA will also have exosomes. So exosomes are the next important research. And look at this beautiful line with which I will end today's class. Robbins said basically, so all of you who are just entering in the medical school now, once you are starting your practices, there will be so many advances in the cancer diagnosis and therapy that you will be mesmerized. Okay, so get ready is the term that you should be knowing. So yes, pathology is an ever evoluting branch, and it follows the Darwin's principles. So yes, be ready for the evolution and keep ready for the update. So you can't be redundant, you have to keep updated. And yes, everything is much, much more than exam preparation. Yes, you have to do exam preparation, but much, much more than that, you have to learn medicine, because this is the subject that you've chosen for life. So yes, keep updating yourself and keep reading well, guys. So with that, we'll end the today's session. I hope you're clear with the today's quiz. And I told you last time also, do let me know how you found the sessions, and if you like them, we can have more of them, right? So your reviews are more important than anything. With that, we'll end today's session. Bye bye, guys, and happy reading, right?